Hi everyone, this is Claudia Gorin from Matana Bay Harbor Islands, and today we have Aventura Hospital joining us again for a health lecture with Dr. David Krieger.
Oh, nice to meet you virtually. My name is Dr. David Krieger. Actually, as I was mentioning before, I live down the block in Surfside. Today we're going to be talking about spinal surgery. The initial topic was spinal fusion. I thought it might be a little bit too technical, but I'm happy to answer any questions about spinal fusion. I'm still going to be just talking about spinal fusion, but I want to put the emphasis a little bit more on some other things, as you'll see. And obviously, if you have any questions, please let me know. So the topic today is innovations in spinal surgery technology. As mentioned, I'm a brain and spine surgeon at Aventura Hospital and Medical Center, and I've been here for about 5 years. So in terms of the first slide, so a lot of patients come to me as a spine surgeon, and they say, I have really bad back pain. I was told I need a fusion to fix it. I want you to do it. I want you to fuse my back. So that's a misconception that most people who have back pain do not need a fusion. It's very rare that people need a fusion. And we'll talk about what some of the obvious cases where people need a fusion, what a fusion means. But usually the answer is no, you do not need a fusion. Some people will come to me and say, isn't there a new technology that can just fix the problem? And with back pain, unfortunately, the answer is no, although we'll talk about some of the answers and some of the new technologies that are out there. So some just quick definitions about low back pain. And this is actually from an article from the 1980s, pretty old literature, but this is the one that's always quoted, that approximately 80% of Americans report low back problems at some time during their lives. In other words, we're basically all stuck as humans that at some point during our lives, we're going to have bad back pain. But back pain does not mean that you need surgery. In most cases, again, at least 80% of the time, when you have back pain, it's going to get better. So even though most of us at some point in our lives have back pain, the answer is usually not surgery. Almost always it'll get better by itself. Sometimes, obviously, people need conservative measures like physical therapy. Sometimes you go to a pain management physician, they can do what's called an epidural steroid injection. But often, just by itself, if you did nothing, the evidence shows that within a couple months, the back pain is going to get better by itself. Now, for people who the back pain does not get better, this can be a real problem in terms of your work, not being able to get back to work. And this could be something that could go on chronically. In those cases, the issue, particularly with back pain, is, as I mentioned over here, back pain is multifactorial, meaning that it's not just one thing that's causing back pain. It's usually more than one thing. And unfortunately, there's often, to be honest, no ideal treatment, particularly for chronic pain that has been resistant to non-surgical treatments, and even more importantly, back pain that has been resistant to surgical management. And we'll talk about that a little bit later. What happens, let's say someone has surgery, are there other things that can still be done for back pain? So new technologies aim to minimize pain immediately after surgery in the perioperative period, meaning before and after surgery, or more directly reduce pain after surgery. But again, as I mentioned, back pain is usually not just from one cause. You may have a young patient who will come in and they'll have what's called a disc herniation that's pushing on a nerve. It'll be going on for a couple of months, and they'll have, in quotes, chronic pain from that disc herniation. In those cases, it could be a very focal problem. I can go in, make a small incision, remove that piece of disc that's pushing on the nerve, and relieve the pain. But there, we're talking about a very focal problem. Usually, as pain gets, usually people who have pain chronically, it's usually not just one issue. It's not just one level in the lumbar spine. It's multiple levels. It's not only a disc herniation. It could be a joint problem. It could be a ligament problem. And it's usually, as I mentioned, not just one problem, which is why it makes it much more difficult to fix. So just to have some definitions, again, because a lot of people, when they say back surgery, think about spinal fusion. So what is spinal fusion? Spinal fusion is rigidly fixating the spinal column with bone healing so that the spinal column is no longer mobile. So a lot of people, when they think of spinal fusion, think about rods and screws, which is the way currently, and I'm going to talk a little bit about the historical perspective, that is the way currently we use to rigidly fixate, because it's been shown that that's the best way to rigidly fixate. But there are some patients who I don't use rods and screws, and I can still fuse. What does fusing mean again? Fusing means bone healing. So rods and screws, even the best rods and screws, over time will, if the bone does not fuse, does not heal, they'll break. Because any device, any titanium or whatever, however strong the device is, with repetitive motion, it will break unless the bone fuses. So the fusion part of it is not the rods and screws, is actually the bone healing. The rods and screws are only a mechanism so that you get bone healing. And to take a step back, the fusion and rods and screws were not designed for treating pain directly. And we'll go through some of the cases where it's obvious that you should be using rods and screws or other devices to help with fusion. So what are some indications for spinal fusion and some alternatives? So spinal fusion was really developed for instability. How do you get instability in the spine? One could be trauma. One could be a tumor, that there's a tumor in the spine itself, and that eats away at the bone, and that causes instability. There could be an infection in the spine, and that infection again eats away at the bone and the ligaments and causes instability, or at the disc even. It could be iatrogenic, meaning someone's had surgery before, and that surgery has caused instability. So that one of the main reasons for a fusion, that is to promote bone healing in the spine, is because there's instability there. Now, we know that there are a lot of cases where we don't do a fusion, even for these indications. For example, if someone comes in with a traumatic injury, they could have what's called a compression fracture, which is not an unstable injury, but they could have a fracture from a traumatic injury. You can use a brace, and we'll talk about some of the historical perspective about bracing. For tumors, often tumors in the spine do not cause instability. For treating pain in the spine, radiation obviously has been around for a long time. And I'm going to mention something later called tumor ablation, where I put small probes into the vertebral body, into the spine, into the bone, and I could actually kill the tumor minimally invasively. And after killing the tumor, I can fix the fracture with cement called a KYPHOPLASTY, and that could be another alternative to doing a fusion. In terms of infection, obviously antibiotics. Even if you do a fusion, even if there is instability and surgery is needed, obviously you're going to still need antibiotics to treat the infection. Now, taking a step back again, one reason for spinal fusion is instability. Another main reason for a spinal fusion is something called deformity. I'm sure many of you have heard of scoliosis. So you can have congenital scoliosis and other different kinds of scoliosis. That could be a reason to change the position of the spine to make it more straight, so to speak, and you could need to do a fusion to keep it in that position. And some people might have heard of the word spondylolisthesis. A lot of patients come to me, have trouble pronouncing this word. Basically, it just means a slip in the bones where there could be instability. And that could happen slowly over time, or it could be from birth as well. And sometimes that can require a fusion to stop the instability at that level. Now, often fusion is used to treat pain, although it's still very questionable whether fusion does help for pain. And we'll talk about a little bit more other treatments theoretically for pain. So to take a step back again, fusion just means that the bone is healed. Why would you use a fusion? Usually use a fusion for some kind of instability that was caused. For example, someone had a traumatic injury, has an unstable spine, and therefore you need to fuse it or cause the bone to heal. A mechanism, a way that you cause the bone to heal is to use, for example, rods and screws to keep it very rigid so that the bone fuses. I hope that makes sense. So now I just want to show a case from a few years ago. And I'm a trauma neurosurgeon also. I do a lot of traumatic injuries. We're a trauma center here at Aventura. And this is obviously a case where anyone, even a layman, can see this is an unstable spine. If you look at the picture on the left, this is someone who was in a motor vehicle collision. These are the bones at the front of the spine. These are the bones in the back of the spine. The bones in the back of the spine are all the way up in the front. And you can see all these fractures over here, all these broken bones over here. So even someone just looking at this picture can say, well, this is something that needs stability, needs what's called a fusion. And you can see this is a picture that I took in the operating room on the right, where you see that there are screws 3 levels above the fracture, 3 levels below the fracture. And now you can see after I've reduced the fracture, this is the normal alignment. So all the bones now you can see, all what are called the vertebral bodies, are all in alignment. These are the screws. You can see this is looking at the spine from the side. This is the top of the screw called tulip head. This is the shaft of the screw. This is down here below the fracture. This was the level of fracture. And there are rods, there are two rods, and you can't see them because you're looking from the side. They're paired, and that will help the bone to heal. We'll keep it in place rigidly and let the bone heal. So this is what it looked like before, and this is what it looked like after reduction. So obviously there are certain cases, this is really what fusion was designed for. This fusion was designed for patients who have a clearly unstable spine. Now, just in terms, because this topic is really about technology and new innovations, I wanted to show you what the screw looks like that I would use for this kind of procedure. So this is the shaft of the screw here, and this is what's called the tulip head. This tulip head is where the rod goes through. And you can see that there's a little cap here that tightens on to where this rod would go. So the rod would go through here. So this is, where I'm outlining here, this is what a normal screw would look like. So one innovation is this little, just small piece at the top of the screw, okay? That little piece at the top of the screw is called, what makes it called a reduction screw. And if we just go back to the picture before, obviously you can tell that this is a procedure, this is a spine that needs to be reduced, meaning this bone needs to come back over here to reduce the spine back to normal alignment. This is after I took off those little pieces of screw called the reduction parts of the screw. To go back over here, that's the reduction part of the screw. So this was a very small innovation to add these little extra pieces of the screw. And what that allows it to do is that allows the rod to be, even though the rod normally, if you can imagine, the rod normally would be way up here as a straight line. If you have little extra pieces of the screw extending up, you can slowly reduce the spine back. Those little extra pieces of the screw, what they do is they allow a little extra space. When the rod goes down, I slowly cinch down these caps and I reduce the spine. So innovations are often very, very small, just like something like this, that little extra piece of the screw that allows the reduction. Something else that I may use in a surgery like this, and again, these seem like very small things, but these are very important. So when I drill, and sometimes I have to drill on the back of the bone, especially in traumas, to be able to make sure that the spinal cord is free, there are drills that we use now that you can use right next to the spinal cord, and they are safer. One is ultrasonic drills. So a drill that cuts bone at a certain wavelength, a certain ultrasound wavelength, that only cuts the bone and doesn't cut soft tissue. So I'm able to use that with infections and trauma and other cases to get around the bone, all the way around the spinal cord without damaging the spinal cord. Another drill that I use, and this is a drill bit that I use very often, is a drill that actually has diamonds around it. And the diamonds, the way that it cuts more preferentially bone than soft tissue. So for example, I did a surgery this morning. I used a diamond bit drill, and that drill is safer to use around the spinal cord. So I want to go back to some historical perspectives. So taking a step back, bracing, as I mentioned, has been around for as long as anyone can remember. In fact, it was first developed by Hippocrates, the father of medicine, in the 5th century BC, where he recognized that scoliosis was something that was progressive over time. And he developed something called the Hippocratic ladder and a board to apply what's called axial traction to try to help with scoliosis. 5 centuries later, Galen designed chest binders, actually very similar to chest binders that we use today in kids for scoliosis, to try to stop the progression of scoliosis. So bracing has obviously been around for a long time. In terms of trying to promote a fusion, the first developments were wires. So screws came later on, and I'll mention a little bit more about that. But in the late 1800s and the early 1900s, wires were used for stabilizations. First used in Texas by a man named Dr. Berthold Hadra, who came from Germany. And again, the development of these screws was for an unstable spine. So Dr. Wilkin used this technique in a patient with a fracture that was caused by tuberculosis. That's what's called a pathological fracture. That means the infection caused the fracture. The fracture was in the bone and it caused an unstable spine. In the late 1800s, he was the first person who used wires to stabilize the spine so that the spine didn't move, to promote fusion or promote a healing. As I mentioned, Dr. Hadra used a similar procedure in a traumatic fracture dislocation. If we go back to the slide that I mentioned earlier, this is what's called a fracture dislocation. So early on, meaning 100 years ago, they initially used wires to do this. So they put wires in to try to fuse the bone to help it heal. Another procedure for scoliosis, this was first done in 1909 to try to straighten the spine, again using wires. In these early techniques with wires, there were a lot of infections. Obviously, this wasn't a procedure that was fully studied at the time. This was just the initial forays into trying to get the bone to heal. So when did this screw fixation, when were these screws first used? It actually wasn't until the 1940s that screws were first developed to try to do more rigid fixation techniques. Even after these procedures, patients needed prolonged bed rest for at least 3 weeks, and sometimes even much longer. The non-fusion rate, the non-healing rate, meaning even if they put these screws in, these were again early forays into this, were up to even 50%. So meaning 50% of the people did not even achieve the fusion necessary. So when were these pedicle screws developed? So again, screws were first developed in the 1940s, but the way that we use screws now, again, sorry, I'm flipping back to this initial slide here, but these screws are going through a part of the bone called the pedicle. When did that first happen? So sorry, going back to the slide again. The pedicle screw fixation, what we now use, which is the mainstay for how we achieve a fusion, was first described in the late 1960s and the early 1970s. I'm going to show you a picture. This is a picture here of the first time of a modern pedicle screw was used. Some people may recognize this. This is called what's called a Harrington rod. This Harrington rod, this long rod here, developed earlier than 1960, was used in the first cases of scoliosis. And what you'll see here is something called a pedicle screw, as I showed you in that picture before. 1969 was the first time that anyone used a pedicle screw. There's a man named Dr. Roy Camille in Canada. These were the initial plates that were used instead of the rods. Again, early forays into spine surgery with screws in the early 1970s. So that's just to give you a sort of a historical perspective. And to give you a summary, the purpose of all these surgeries to achieve a fusion, to achieve a rigid fixation, the reason for all these surgeries was because of an unstable spine. Okay, so I wanted to talk about some new technologies, and there are a lot of technologies to talk about in spine, but these are adjuncts to the fusion that I was talking about. And I'll talk about some things that may be interesting to you. One is robotics, because everyone is always interested in robotics. So I want to talk about how robotics are applied in neurosurgery. I was one of the first people in the country to really use robotics in neurosurgery. There are a lot of still limitations from it, and I'll talk about those, but I'm going to talk about robotics in neurosurgery. Something else is called neurostimulation. As I mentioned before, a lot of my patients, a lot of other people's patients, let's say you've done everything that you can in, let's say, the lower back to help fix the problem, and people still have pain. Again, a lot of times you're treating the pain. How do you treat the pain? If everything can be done, or you think can be done from a surgical perspective, there are still other options, and one of those options is something called neurostimulation. And I'm going to talk about more in depth. And this is a procedure that I do a lot for people who have sort of failed all other algorithms. They failed surgery, they failed pain management. Is there anything else that can still be done? And neurostimulation is one thing that I do, and I did a procedure like that this morning in the hospital. Something else is called cement augmentation. When I was in training, really it was a radiologist who did cement and did minimally invasive procedures to put cement in to treat fractures. Now as a neurosurgeon, I'm using that a lot more, and it can be used in creative ways, even for traumatic injuries, where in the past, we would have to do multiple stage procedures to go in the front of the spine, in the back of the spine, to put large instrumentation, large instruments to hold the spine in place. There are some times where I can use cement as an adjunct to a fusion, even in cases of an unstable spine, to help with injury. So I'll talk about that as well. So what are robots, and particularly what are robots in neurosurgery and spine surgery? So here's a cartoon. I suppose you're the brains behind the operation. So many people think that it is the robot that somehow is doing the surgery. And particularly with spine surgery, this is not the case at all. With spine surgery, a robot is only used for a navigation device like GPS. Now in general surgery, it's a little bit different. In general surgery, there are robots. You may have heard of something called the Da Vinci robot, other robots, where a surgeon is standing remote from the robot, and the robot is actually doing the suturing or doing the surgery. In spine surgery and in neurosurgery and brain surgery, the robot is not doing it. The robot is just a navigation device. Maybe at some point in the future, it'll be the robot that actually is using the tools, as is pictured here. But to date, that is not the case. What is happening is that the neurosurgeon, the spine surgeon, is doing the surgery. The robot is only used as a navigation device. Now, I know this is generally a lecture on spine surgery, but I just wanted to show you some pictures. This is for what's called deep brain stimulation, which can be used in, for example, Parkinson's disease. So this is an example where we've used robots before. So for example, in the case on the left, this big frame over here, which is applied to the head, this is in a case where a robot was not used. And you can see the surgeon here slowly putting a small wire, and this wire is put into the brain. And the way that this wire is put in is through very precise coordinates that are measured with this device that's here. Over here, a frame is still used, and there's still this arm that's here, but there's not this huge frame that's around it. And the reason for that is that the robot is being used as a navigation device. Again, the surgeon is still going to have to use his hands to slowly place this in. And there's something over here. There's a device that slowly pushes this needle forward into the right position. But the robot arm is used as a navigation device. And I'll show you how this works in spine as well. So robotics in neurosurgery equals navigation. The robots are not doing the surgery. It's used as like a GPS device during surgery. So what are the different spine devices? There's one that's a direct attachment to the spine or brain. There's something, MAZOR is an Israeli company and was one of the first companies to develop it. One of their first technologies is called the Renaissance technology, and I'll show you a picture of that. And I'll show you what this means, a direct attachment to the spine or brain. And another technology is a robotic arm, more like you'd expect from what one might call a robot, something that looks more like what an actual robot would look like. And their device is called the MAZOR X, and I'll show you some of these pictures. So on the left is a robot. Now, it doesn't really look like a robot, but I'll show you what the robotic part of this is. So as you can see, the surgeon is doing all the activities of the surgery. The robot part of this is only this device over here. It's a little arm that projects out, and by its projection, it shows where the screw is going to be placed. And I'll mention how this goes. So first, a small incision is made in the skin. This robotic arm shows where this device is supposed to go into the spine. Through that device, you do a small drilling. You put this small cannula in, and through that cannula, you put a wire. So the robotic arm is only allowing you to show you where to put that wire in. And after you have the wire, you can put a screw through it. And in a pictorial sense, this is what the robot looks like on a head. And again, this would be a way to use this. This is attached to the head, and the robotic arm is showing you where to place this wire that goes into the brain. So this is not what we really think of as robots, but this is the robot technology, the early robot technology. And this is what a newer robot technology looks like. Let me see if it'll play. So they even made it look like a robot. And this is what's called the MAZOR X. So this is what you would think of more like what a robot would actually look like. But what we're doing here, again, I'll just go back to the beginning. This is the robotic arm. The robot does not have fine devices to be able to do surgery. It's really just this inner piece here that directs the area where the screw is going to go. So it's really just a navigation device. And I'll show you in the next slide what that means. So this is a surgery that I did, for example, with a robotic device, okay? Just to give you a sense of how it works. So what you can see here, these are called K wires. These are wires that I'm putting into the spine. And I'm putting them through that area called the pedicle. This was a man who had a very, very bad infection in his upper spine. And you can see how the bone is eaten away over here. And it was so bad in the upper spine that he had a instability there. The bones were moved. They weren't in the right place. And I had to put them in the right place, essentially, with these screws. It was a difficult surgery, particularly in this area in the upper middle of the back, the upper thoracic spine. This is the patient's neck over here. This is his upper back over here. That's a very difficult area to see with X-ray. And this is actually an X-ray seen during surgery. It's very difficult to see with X-ray because the arms are in the way. The arms would be projecting right here. So that's why I use a robot to try to help me with guidance, navigation. Again, I did the whole surgery. It was me who put in the wires, me who put in the screws, but the robot allowed me to navigate the surgery. What you're seeing here is this probe is going down, is being placed on the bone. Through that probe, I'm able to drill and put a wire through it. And through that wire, I'm able to, the screws have little holes in them. I'm able to put the screw through the wire into the bone. And this shows what happens after surgery. This is a large cage. As I mentioned, sometimes I can use cement, but particularly with infections, you can't use cement. This is a large expandable, what's called a titanium cage in the front of the spine. And I use a general surgeon to help me get into the front of the spine to fill out this defect over here with this large cage. And this is the back of the spine, seeing those rods and screws. So again, this is using the robot. The robot is only used for navigation purposes. So how are these robots used in spine surgery? In theory, there's more accuracy. In theory, it's a faster surgery. In theory, there's less blood loss, but none of these things have been proven. In fact, I can't say with clear evidence that in spine surgery, that when I do spine surgery with a robot, or if I do it with just X-rays, that there's any clear advantage. And to be honest with you, I mostly don't use robots in spine surgery anymore. But that is, I was one of the first people to use them. Studies have not shown any difference between X-rays and robotics. There are still indications for a robot, but they're much smaller indications. Now, I often use, which has been shown to be more accurate, an intraoperative CAT scan. That means I do a CAT scan picture during surgery. And the reason that I do that is I'm able to navigate, as in GPS, off of this CAT scan. And this is how the CAT scan is done. The patient goes through that hole, or take a CAT scan during surgery, and I'm able to navigate or use GPS during surgery. And that has been shown to be more accurate. Excuse me. So that's sort of a quick summary of robotics. I want to go on to another topic. Just to talk about, a couple other small things about robotics. Robotics has been used a lot in brain surgery. Let's say someone has seizures and needs wires placed to try to predict where the seizures are located from. Robots have been used. This is a different kind of robot called a ROSA. This is showing a picture of a patient where the wires are placed by the robot, meaning that the robot is really being used as a navigation device to place these wires. Okay, so I want to go on to a different topic. As I mentioned before, we're talking about spine surgery in general. Let's say someone has had back pain for a long time. Let's say they have gone through multiple spine procedures, including going to pain management, and they still have back pain. I want to mention something that you may not have heard of before called spinal cord stimulation. Now, this has been around for some time, but we're getting a lot better in terms of treating people's pain with this modality. So what is spinal cord stimulation? It's what's called a neuromodulation technique to treat chronic pain. This is still a surgery, but it's done to treat pain. In other words, a lot of spine surgery was developed to treat instability. And this is a specific modality to specifically treat people's pain. How does it work? It modulates the dysregulated pain pathways by mechanisms that are not fully understood. But this is a device that's placed on the spinal cord itself, and it somehow modulates the pain both at that level of the spinal cord and in what are called other mechanisms, even going up to the brain. There's no tissue that is lesioned or injured. The procedure is fully reversible. As I mentioned, it involves placement of a surgically implanted electrode in what's called epidural space or on top of the spinal cord. The power is supplied by an implanted battery. For example, if you know about a pacemaker, pacemakers are implanted with a battery, and that's what allows a pacemaker to work. This is how this device works as well. And the difference between this and other things that I mentioned, these are designed specifically to treat pain. So neurostimulation, again, is the process of using electrical stimulation to modify neuronal activity. versus an activity like lesioning where the tissue is destroyed. So this does not destroy any tissue, it's fully reversible. But again, for some reasons that we don't understand, it re-educates the spinal cord. If you would stop the stimulation, you will even see differences in how the spinal cord reacts even a day after this is stopped. So somehow this is modulating the spinal cord, not only while you're doing the electrical activity, but even afterwards. So for example, in sometimes you have to actually lesion the spinal cord. In very, very sick patients and patients with very, very bad tumors, for example, sometimes you need to do a procedure called a DREZ, where you actually lesion the dorsal root entry zone or part of the spinal canal to stop the pain signals, where you've actually cut it. And that's how it works. In spinal cord stimulation, the electrode is placed over the dorsal columns or the back of the spinal cord, and as I mentioned, it interrupts the pain signals. Somehow it modifies these pathways even after the spinal cord stimulator is turned off, and it's not fully understood. And I want to show you a couple of pictures just to give you a sense of what it looks like. So this is a procedure that I did, for example. This is the thoracic spine, or the middle of the back, and this is looking straight on to the spinal canal. And this is an electrode, and it's hard to see because you're looking straight on, but this is an electrode that's actually placed underneath the bone in the back of the spine, and it's on top of the spinal canal. This is an MRI image looking straight down at the spinal cord. This is where the spinal cord is located. This is the front of the patient. This is the back of the patient. It's a procedure that I did. And you can see this black over here is this device that's on top of the spinal cord. Okay. And this is an X-ray of, people rarely do this, but I'm actually a surgeon who does do this, doing surgery even in the neck. So generally this is a procedure that's done for low back pain, but I've done it successfully in patients, for example, who have had all other surgeries, nothing else can help them, even in the neck, to treat arm pain and neck pain, to do this procedure, to put the stimulator in to help with neck pain. So again, as I mentioned, there are batteries. I use all the different devices, the main devices that are on the market. Medtronic has a device, Nevro, which is a new company, has a device. This is St. Jude, which is a device I use a lot, and this is also Boston Scientific, and this is a picture of me being one of the first surgeons to use one of their new devices. So this is a technique that I'm very familiar with. And again, these are patients who have intractable pain, and this is a good way to try to treat intractable pain, whereas before there was no way to treat that pain. Okay. This is probably underutilized in the United States. We know from studies in Europe that this is used for peripheral vascular disease. In other words, not for neurologic pain, for people who have bad blood vessels in their legs and have very bad pain from that. This technology that I was mentioning is actually the most common indication that it's used for in Europe. For this specific indication, it's rarely used in the United States. We also know that it treats intractable angina. In other words, let's say a patient has to go for a coronary artery bypass graft because they have intractable angina. There have been studies that have shown that this device that treats pain is as good as that procedure, as good as a CABG procedure to treat pain. Because again, this is trying to treat pain directly. The main indication to use it in the United States is what's called failed back surgical syndrome. These are patients who have previously had surgery. Some people may have heard of something called chronic regional pain syndrome. People who have really significant pain that can't be treated by any other means. The spinal cord stimulator, again, can be a very good treatment for that. And also people who are not surgical candidates, but again, this is something to treat pain. Okay. I want to move on to another topic. Cement augmentation and kyphoplasty. This is something that I mentioned before, maybe of interest to you. So cement in the past was used mostly by radiologists to treat fractures, for example. Now, in training, that's all we use it for, but now I use it a lot more for other indications, and I still use it for people who come in with fractures. For example, this was an elderly gentleman who came in after a fall and had a broken bone. And that broken bone, he was in severe pain. He tried other methods and was not able to help with that pain. What I did was I put cement into the bone. This is cement that you see. This bone, as you may be able to tell, is very osteoporotic. And I put the cement into the bone, and that helped heal the bone, and he did not have pain afterwards from that fracture. There are some people who come in, it's a little bit hard to tell because I've already reduced the fracture. There was a bad fracture in this bone, particularly over here. The bone was not aligned properly. The patient needed a fusion. I put the screws in at these levels above and below where the fracture was located. This patient had very bad osteoporosis, and I was worried that these screws would not hold in place. and wouldn't achieve the proper rigidity, the proper fusion needed. So what I did was, and this is hard to make out, but if you can make out, there's a little bit of haziness around the screws over here. There's no haziness here, but there's some haziness around the screws. What I did was I put cement through the screws. These screws are what are called fenestrated screws. They're very small holes in the screws. I did a CAT scan picture in the operating room. I was able to see that the holes were in the good place and were safe to put cement through. I put cement through the holes. And what that does is it gives extra stability. It holds the screw in place, particularly with patients who are very osteoporotic, who are worried about the rods holding. Another way that I use the cement is for patients with bone tumors. Patients who have severe pain from, for example, metastatic lesions, these are tumors that come from somewhere else in the body and go to the spine, just as an example, they can really destroy bone, cause instability, and also cause pain. So for example, for painful bone tumors, I can do a minimally invasive procedure where I put small probes into the tumor and into the spine, into that bone, and I can kill the tumor through those small little probes. And then afterwards, after I've killed the tumor, I can put cement into where that tumor was located, and that can improve the stability and can help with pain. So this is just a pictorial of how I would do the procedure. This is the bone in the front. I put these small needles into the bone. This is where the tumor would be located. These are the small radio frequency probes that go in. And this can be done as an outpatient procedure, for example, where I can send you home the same day. And these probes go into the tumor. This kills the tumor. And then afterwards, I can put probes down the same direction, put cement in, and that can fill up that space and help with the pain, for example. So I know that's a lot of different topics. We went from fusion, the history of fusion, how it first started as a mechanism for instability, how it progressed into different techniques using screws and rods to treat really bad fractures, for example, in trauma. And we talked about some of the different new technologies, and obviously there are a lot of other technologies that I can talk about, but we talked about robotic technology. We talked about different ways for treating pain that's not a fusion, for example, spinal cord stimulation and cement augmentation. We talked about cement and in the area of spine tumors. I know that's a lot of information, but in terms of some theme caveats for neurosurgical technology, spine surgery technology specifically, is obviously important to understand and be facile with a breadth of technologies. In other words, when I was in training, I might have only learned one particular type of technology, but it's important to always be familiar and to learn new technologies. It's always a learning process in spine surgery. So when I was in training, I never used any robots. This is something that I became very facile with after training. Cement is not something that I ever used in training. This is something that I became facile with after training. The best new technology is usually small improvements from an existing technology, like that small extra piece on that tulip head that I mentioned for the screw that's more easily able to reduce the fracture. All new technologies are still a work in progress, particularly robotics in spine surgery. It's still really a work in progress. Advancements often come in related fields, robotics particularly, but in everything, for example, what radiologists are doing is important for how we can end up treating our patients. So I know that's a lot of information. I'll stop there and I'll just ask for any questions that people have. I hope I'm not too over time, about 40 minutes. I'll leave you with this little cartoon. I think this is how we feel a lot when we go to the doctor. Claudia sits up here.
Usually they jump in to say thank you and so to end.
Claudia, are you there?
I'm here.
Okay. Well, if no one has any questions, I'm always reachable, and we can also leave my email if anyone has any questions. If someone watches this video later, has any questions, would like to reach out to me, please do so. And again, my name is Dr. David Krieger. I'm at Aventura Hospital. I'm a brain and spine surgeon. Okay, yeah, I can show this up here. If that's clear. You can see my email on there.
Yeah, Bianca will send it to me, and I could also have it. People reach out to me, and I could also just give them the information.
Okay, great. Well, if there are no questions, thank you very much.